2 of the FMC, the Fetal Management and Chemical Biologicals Handbook. That's what we're doing right now.
So you guys just covered a lot of this with your last instructor. It's going to be somewhat redundant, but redundancy is good. It's typically what keeps things in our memory and helps us score better on the test. So chapter 2 is vesicants. Is everybody where they need to be, or do I need to wait up a second?
We have a section for Alvarez.
We do. I wanted to teach these super fast.
Okay, no. She's
Alvarez is, because my class is I'm supposed to teach all this stuff like way earlier. Alvarez is supposed to be from 1415 to 1520.
Yeah, we're way behind.
Yep. I'm going to fly through these. All right. So vesicants, or what's another word for vesicant? Blister agents. Good. Composed primarily of, does everybody know the 3? There's technically 2, and then you have the mix of the 2. What are the 2 agents that are primarily used? Say it. I just heard somebody say it. Say it loud. That's okay. H, which is what? Mustard. Mustard. Yes, H is correct. Mustard. And what's our other one? HD, which is hydrogen mustard. And what's our other one? Lewisite. Good. So sulfur mustard, H and HD, and then lewisite. Or HL, which is a mixture of the 2. And those are the only 3 this chapter talks about. What's up? Do you have a link to the Google Classroom?
Yep. Yeah. If your email's on this paper right here, I'm going to send it to everybody. And then if you have other people, I'll give you my email, and then just tell them to email me. So D Stanway, STANWAY 24 @gmail.com.
We'll see. All right. So mustard rapidly penetrates the skin, causing both localized cellular damage and systemic damage. It was the largest cause of chemical casualties in World War I, and it was used extensively by Iraq in the Iran-Iraq War in the 1980s.
Oh, hell yeah. Ooh, that's a different PowerPoint.
Is it a different PowerPoint?
It's okay.
It is a different PowerPoint. Oh, good. Yeah. All right. So again, HHD, sulfur mustard, L is lewisite, and HL is mustard and lewisite mixture. Physical characteristics: warm and humid, increased severity, and it increases the severity and onset if the climate is warm and humid. The cold delays the onset and is lessened in severity as it stays cool. And high vapor density collects in low spots. So valleys or closed spaces, anywhere where fog is going to appear. It'll settle in those areas. So the odor of mustard, garlic, or onion smell where it shouldn't be is a really big cue to a vesicant attack. Color change will happen on your M9 tape or your M8 card.
Which one indicates the presence of an agent? Which one actually detects the agent?
So this is typically dispersed through helicopters spraying it, or artillery that has a dull or muffled explosion sound. And it feels like oily rain. And the rain part, it's not just oily, it's oily rain. And that's been on the test quite a few times. Thicker, oily liquid on equipment, plants, or terrain. I would know this chart. I'm not going to go over every single description from mild to severe and all that stuff. I would know the chart. And I would know your onset time. So mild is 4 to 12 hours. Your severe is 1 to 2 hours.
Quick question, too, for your M9 detector tape. Does anybody know where that's placed on the body? Ankles, wrist, and? Biceps. It's a test question, so just know that's where you're placing your M9 detector tape.
So decontamination after 2 minutes will not prevent a mustard injury. H for your H and HD. HL, immediate intense pain to eyes and eyelid twitching. Pulmonary edema, which is fluid in your lungs, right? So immediate mission-oriented protective posture, or MOP level 4, is required for vesicants. I would know that. Remove suspicious liquid using RSDL, which is soap.
Reactive skin decontamination lotion.
It's a lotion. It's a lotion soap. And it says if you don't have that, then lots of soap and water. Flush eyes with copious amounts of water. And it must all be done within 2 minutes to prevent the agent from being fixed to the tissue. It will jack up your skin and your lungs and your eyes. RSDL is the reactive skin decontamination lotion kit. And the M295 is your individual equipment detector kit for equipment. I would know both of those. Mustard conjunctivitis, you treat with steroid antibiotic ointment like dexamethasone, sodium phosphate, neomycin, ophthalmic ointment. You issue narcotics for pain. You do not bandage the eyes because it seals it in, and that would burn like a mofo. Petroleum jelly or antibiotic ointment on eyelashes to prevent abscess formation. And you evacuate the patient if more than 5% of the body is affected. Topical steroid cream or calamine lotion for your skin, because the patient's going to have blisters on them. All the little tiny blisters, you're going to leave them alone. If the blister is the size of a quarter or larger, and it says this directly in this chapter, if it's the size of a quarter or larger, you unroof them, meaning you peel them off. Okay, if they've already broken open on their own, you get rid of all of the jagged tissue, and then you put on the steroid cream bandage or a petroleum jelly bandage so that it doesn't stick to the skin. What is our main concern for blisters? Infection. Infection. So you always want to clean it, bandage it properly. And that is it for that one.
Gucci.
Any questions over vesicants?
Sweet. So we got chapter 4?
Chapter 7.
7.
Chapter 7 is our biological agents.
Bam.
And this one's 18, but we'll get through it pretty quickly. So developed from living organisms and viruses capable of causing disease and death in humans, animals, or plants. You guys just went over this topic, correct?
A little bit of it, yes.
Not all of it, but yeah, you guys touched on it, right? She talked about gram-positive organisms and stuff like that. So 2 classifications. You have your lethal agents, which obviously lethal means death, which means high mortality. And then incapacitating, severe illness, but not death. You have your biological toxins or biotoxins, poisons derived from plants, animals, or microorganisms. Rapid onset. Examples are staphylococcal enterotoxin B or SEB, and botulinum, and ricin. Ricin has been the most commonly talked about. Biological modulators, response modifiers, are substances that modify immune responses and substances that arouse the body's response to an infection. So pathogens are your microorganisms that cause death, like bacteria, rickettsia, and fungi, and viruses. Classic biological agent of choice is pathogens. So like Bacillus anthracis is anthrax, right? That is a pathogen. Respiratory tract, digestive tract, and skin are your points of entry. Physiological manifestations. So during attacks, patients who have not been exposed may experience fear, anxiety, or panic, of course, because they're watching everybody else. fall down and die, right? Expect, it's a little dramatic, but you know what I mean. Expect numerous indirect casualties from psychogenic illnesses. So a lot of people that are like, oh my God, I'm dying, and they weren't ever exposed. Biological weapons attack recognition, they are difficult to identify early on because it takes a long time to grow this stuff, especially in a field environment, trying to keep a sterile field, deplate it and put it in an incubator, right? So you're going off of mostly symptoms and you're just trying to figure it out. It can be spread through sprayers, artillery shells, mines, missiles, crop dusters, jets, modified fire extinguishers. The aerosols can contaminate food and water. That's typically our biggest issue if you read the chapter, where it's contaminated the food or the water and people are ingesting it unknowingly. Appearance, non-oily, translucent, and slightly more viscous than milk, usually light brown or amber appearance, but can vary in color when dried. I don't know what it's talking about on this slide because all of the different organisms kind of all represent differently that could possibly be used. So I don't know exactly where that information came from. But skim over the chapter, find the appearances of your biological weapon attacks or biological weapons, and they're pretty much colorless, odorless, tasteless, because they can be just put into your food and you would never even know it was there.
It just says liquid biowarfare agents are non-oily and are typically translucent.
Okay, so
and slightly more viscous than milk.
Right, so if they aerosolized it, that makes sense. So it's just clear.
I have seen more viscous than milk somehow on the test before. I know I've seen it.
Weird, okay. All right, detection, biological integrated detection system, very limited number in the military due to cost and issue. We don't have these guys. Samples should always be taken, you don't have them downrange or on ships. Like the bigger units might have one, but samples should always be taken if suspicious and given to laboratories for evaluation. Give it to me, I will put it on a plate, put it in my incubator, and pray it grows in time before the patient dies. Sample processing. Take samples from patients using synthetic swabs made out of rayon. Cotton kills a lot of bacteria, just for you guys' information. So we don't typically like CTAs. We want rayon swabs because rayon doesn't kill the bacteria. Litmus paper to pH, alkaline versus acidic. And if near neutral, 7.0, there's a chance it could harbor human pathogens. Qualitative ninhydride test detects amino acids, which again is biological, right?
And she'll tell you as a lab tech, know your pH levels, especially what neutral is. You're going to see when we go over chapter 19, the HM manual, those pH levels help you indicate certain things, certain diseases.
Know your normal pH level for urine, because that is on your test. pH is important for a lot of things, so I would know your pH scale and kind of what is associated with which end and what's neutral and all that. Epidemiological clues of biowarfare attack. Tight clusters of casualties, so typically anybody that like rooms together or a very specific set of people that were all in the chow hall at the same time, things like that. High infection rates, so like if it's at the chow hall, then everybody's pretty much going to get it, right? And it tends to go in that flow of, okay, this group of people was there, and then that group, and then it's like everybody kind of starts dropping in that order. Unusual geography, apparent aerosol, route of infection with more than one biowarfare agent, unusual clinical presentation, unusual munitions, animal epizootics, sentinel dead animals or multiple species. They talk about dead birds. That was on our test, the dead birds. I can't remember the question though.
There were some weird questions on that test.
There were some easy ass questions, chapter 6, but there were some weird questions on our test this time.
Dead rats or something dealing with plague?
The plague, because the plague for some reason was on our test, like we're dealing with the plague again. Lower attack rate among the protected. So as in like, if you had super good case in point, if they give you a scenario where like you have people that are quarantined in medical and they're not sick, but then you have all these people that went to the chow hall and they're sick, what type of attack would you assume? Biological.
Anybody ever watch Walking Dead? So one of the scenes they have in Walking Dead kind of explains this perfectly. They had outside of the jail, they were building a farm and they had pigs. Well, the pigs ended up getting infected with some sort of disease and died. And when everybody ate those pigs, they ended up like contracting that same disease, and it started slowly killing them. So same kind of concept there.
So your initial response is it's the same as a chemical agent exposure, the initial body's response. Mission-oriented protective posture, or your MOP, is masking alone may be sufficient if it's a respiratory thing. Then just wearing masks might be sufficient, right? But it's going to depend on what it is. You're not typically passing this stuff from one person to another. Hand washing helps, right? We're talking about bacteria and viruses. This is the normal stuff we're dealing with every day. Decontamination. The aerosolized pathogens are very likely to adhere to people, clothing, or equipment, so wash everything. Heavier particles fall to the ground and decay over time due to conditions. Bacteria and viruses like hosts. After 24 hours, most agents pose little threat, so if it's on the ground or on equipment after 24 hours, you're pretty much safe. Consider mass showering. Can use fire in water trucks or garden hoses for clothing and things like that. You burn it, right? Water trucks and garden hoses to just mass shower everyone. Soap and water is sufficient. 0.5% hypochlorite, which is bleach, solution is more effective, especially when you're talking about viral things. The bleach is really helpful. So things that are lethal: anthrax, the plague, smallpox, tularemia, which is Francisella tularensis, is the name of the bacteria. And things that are incapacitating are cholera, Q fever, and lethal or incapacitating, depending, is viral hemorrhagic fevers. So there's a lot of viruses that cause hemorrhagic fevers. You can look them up if you want to. And some of them, depending on your health, your level of health at the time of contracting it, it can absolutely kill you. Inhalation anthrax is Bacillus anthracis. I would know that. That's been on a lot of tests.
Mm-hmm.
Bacteria that can affect with fatality rate if untreated. On the skin, it's only about a 5% mortality rate. If you are inhaling Bacillus anthracis, you have a 10% chance of living. Bacillus anthracis aerosolized or powdered and inhaled is going to kill you. We are not going to discover what you have fast enough to save your life. I'm telling you right now. That's why when anthrax came to the United States, it was so scary. Okay? A lot of you are too young to even remember that happening, but some of us older folks remember, right? That was
It's right around the
some serious terrorism,
Yep.
right? People think that it's just anthrax. No, the shit's real.
It's not Ebola.
Mm-hmm. Gastrointestinal tract, so if you ingest it, you have a 30% mortality rate. Not so bad, because it takes longer to incubate, and you have has a lot of barriers, like all your gut stuff. You have natural bacteria and stuff in there. Your lungs are a sterile environment, so it just like flourishes there. All right, characteristics: 1 to 6 day incubation. I would know that. Symptoms: malaise, so just feeling crappy, fatigue, myalgia, body aches, right? I would know the technical terms because they're going to use the technical terms on your test. Headache, dyspnea. What is dyspnea? Difficulty breathing, shortness of breath, chest pain. The chemoprophylaxis is ciprofloxacin or doxycycline. I would know that as well. Chemotherapy is IV Cipro or Doxy. So as soon as we suspect you have anthrax, we are going to start you on an IV of Cipro or Doxy immediately. Even if we're not sure, but if we suspect, that's what we're starting you on.
Treat empirically at that point.
We do treat empirically at that point. We don't wait for cultures to grow. If we think it's even a remote possibility, that's what we're starting with. Because again, 90% chance of death if you've inhaled it. So, or simultaneously using 3 to 4 of the ciprodoxy, amoxicillin, or penicillin. You use 3 or 4 of these. So take all 4 of them and mass dose your patient. Anthrax vaccine, it's 5 shots over an 18-month period. They're way less violent now than they used to be. The anthrax vaccine used to suck really bad, but I would know that 5 shots over an 18-month period, that's one on the test as well. Again, I would know IV, Cipro, or Doxy. The 3 or 4 of the 4 that are listed are, probably not on your test. The IV, Cipro, or Doxy is probably on your test.
Again, chemotherapy or prophylaxis is always going to be the questions they're going to ask on these diseases on the test.
This is a big one. I've seen bacillus anthracis on every test. Every test I've taken. Cholera, I think I've seen one question recently. It's an acute bacterial infection of the GI tract that's spread through sabotage of food or water supplies. Incapacitating agent with incubation period of 4 hours to 5 days. It averages 2 to 3 days. If left untreated, it has a mortality rate of 50%. Symptoms are painless diarrhea. So rice water stools was always the key term or the key verbiage in the scenario-based question that they'll ask you.
Correct.
So rice water stools is what you're looking for. If it's rice water stools, it's cholera. The rest of it's kind of whatever. Chemotherapy, aggressive rehydration with oral rehydration solution or IVLR, so lactated ringer. Doxycycline, 100 milligrams, 3 times a day. Or twice a day, I apologize. Twice a day, or what is TMPSMX? I don't know what that is.
I don't know, I have it, 100 milligrams.
Methoxazole, is that what that is? Sure. I've never seen it abbreviated like that. That's what it looks like. It's a dual antibiotic. They're not going to ask you these. It's going to be Doxy, 100 milligrams twice a day with IVLR, if it even asks you the chemotherapy. It's typically a scenario-based question of what agent gives the patient rice water stools, and it's cholera. I think that's really the only cholera question I've ever seen asked.
Sabotage food or water.
Or sabotage food or water. Yep. Sorry. You were right. Plague is caused by Yersinia pestis. It's a bacterial disease with main threat coming from aerosols that cause the pneumonic plague. So Yersinia pestis causes a couple different types of plague, but the pneumonic plague is the one that's inhaled. Pneumonia, hence pneumo, right? So it has a safety pin appearance on gram stain. So when you gram stain it and put it under a microscope, it has a safety pin appearance. I've seen that on a lot of tests, but I've been a lab school instructor, so it may not have been an advancement exam question. Incubation periods 1 to 8 days. If left untreated, 60% mortality rate for bubonic plague. And for pneumonic plague, it's over 95%. If you get pneumonic plague, you're dying.
Know that it comes from fleas too. So the things that come from they love throwing on the test diseases that come from certain pests, fleas, insects, whatever, right? So know that the secondary threat for plague is fleas.
Yep. So fleas bite rats that have Yersinia pestis, because rats can live with Yersinia pestis. The fleas bite the rats. The rats don't bite the humans. The fleas bite the rats and then get on the humans and bite the humans and transfer the Yersinia pestis from the rat to the human. It's a vector. And that's test questions too. Vector, what's the vector for Yersinia pestis? It's fleas. Okay? What is the host for Yersinia pestis? It's the rat. Symptoms, fever, buboes. So if you have the bubonic plague, it's buboes. Not the pneumonic plague. You don't get buboes with the pneumonic plague. Severe pneumonia is the pneumonic plague. Severe pneumonia from Yersinia pestis, you're dying. 95% or more chance of death. The rest of the stuff is normal. I mean, skin changes, blackening of the skin at extremities, septic shock. I mean, septic shock happens with a lot of things. Chemoprophylaxis, doxycycline, Cipro, and tetracycline.
Again, these all have very similar chemoprophylaxis, but each of them has one unique one to that disease. So I would challenge y'all to study that one unique one instead of just studying doxy and Cipro and all of them. Otherwise, you're going to get confused.
So your chemotherapy for this one is your streptomycin, and that is your one. That's your outlier. That's the one I would know. Streptomycin IV or IM. Almost there, guys. So Coxiella burnetii causes Q fever. It's rickettsial or vector-borne as well. Non-specific febrile illness or atypical pneumonia can be aerosol or contaminated food. Self-limited febrile disease. What does self-limited mean?
Goes away on its own.
Goes away on its own. 2 to 14 days. Incubation period 7 to 41 days. It's usually 2 to 3 weeks. So you'll have it for quite a long time before you even show symptoms. Severe headache, chills, myalgia, fatigue, high fever, dry cough, sweats, pulmonary embolism. What does this all sound like? All the shit that we just went through. Sounds like the flu. Except
COVID?
the new flu. Right. Sounds like COVID. Chemoprophylaxis is doxy, except this is a bacteria, right? Doxy, start 8 to 12 days post-exposure if possible. And it's doxy, Cipro, or trimethoprim sulfamethoxazole. Systemic viral illness like smallpox or variola major. I haven't seen a lot on smallpox on the exam, you guys.
Only about the name. That's about it.
Yeah. Variola major. Rigors. Because that's like an outlier. It's a rash that progresses to pustules, and then scabs and scars. Vaccine. The vaccine is the only chemoprophylaxis we have, and supportive care only for your chemotherapy. We don't give you anything. It sucks.
Got a question back here.
What's up?
Usually the questions are about the vaccine and the applicated needle and scarification.
So that, exactly. And that question is going to be, the answers to that, those questions are going to be found where? In your Corman manual. Okay. Tularemia or Francisella tularensis causes tularemia. It is the smallest bacteria that you can gram stain and see under a microscope. It is gram negative, so it's pink-red. It causes pneumonic or typhoidal forms, and it's 30 to 60% mortality rate. Highly infectious. Incubation period is 1 to 21 days. Mucous membrane lesions. That's your outlier on this one that I've seen on the test.
So the thing she mentioned too that I want y'all to go back and look at is the gram. You say gram negative?
Gram negative. So this is the thing. The Francisella tularensis is also listed in your Corman manual. Where you see things listed multiple times in multiple manuals is where you're going to get a lot of your test questions from. It is a tiny gram negative rod. It is a tiny gram negative rod. It is highly infectious. We usually talk about the pneumonic form because you get it through coughing on people too, right? And it presents with mucous membrane lesions. A tiny gram negative bacteria that presents with mucous membrane lesions, Francisella tularensis. And please don't be offended, but Francisella tularensis sounds super French to me, so I called him the tiny little Frenchman when I was lab school instructor. That's how I got my students to remember who he was, like what he looked like on gram stain. He's my tiny little Frenchman, so he wears pink, and he's super tiny. Okay. I hope I don't offend anybody. Viral hemorrhagic fever. Ebola virus, Marburg virus, Hansa virus, dengue, yellow fever, Lassa fever, Rift Valley fever, Crimean Congo hemorrhagic fever and Argentinian, Bolivian, Venezuelan, Korean hemorrhagic fevers. There are so many, okay? We were talking about all of the hemorrhagic fevers. There are so many. Incubation period can be anywhere from days to months. Definitive diagnosis is only through sophisticated lab tests, which, by the way, we are not doing on you because we are not paying for that. Symptoms, fever, myalgia, wow, malaise, fatigue, petechia. What's petechia? Or petechiae? Yep, little spots. Right. It's just like your little blood vessels just popping under the skin. Hypotension, what is hypo? Low. Okay, so low blood pressure. Multiple organ system failure. Super fun times, right? And then ribavirin is our chemoprophylaxis. So there's a lot of different chemoprophylaxis, but there's the one name, ribavirin. It helps us not contract the viral illnesses that are all listed at the top. And then ribavirin in an IV if you do contract it.
So for the fevers, what they love to do, that's not on the slide that I want you to go back to look at, they love to ask how the fevers are caused for these. That's what they love about hemorrhagic. Is it a tick bite? Is it what is causing this? That is what they're going to throw on the test.
A lot of times these are through mosquitoes. Most of these are
yellow fever is dengue heads.
Yeah.
Rift Valley.
Yeah. Most of these are through mosquitoes. So that's a big part of that. So viruses are very commonly contracted through mosquito bites.
Hantavirus is not.
No.
Nope.
That's mouse poop.
Hantavirus is mice poop, or the fleas that.
Flavivirus was fleas, wasn't it? Or ticks? Tick bite?
Ticks.
Tick bite.
Flavivirus and rickettsia is spread through ticks as well, and that's a bacterial infection. Or Rocky Mountain spotted fever is through ticks as well.
Again, that's probably what you're only going to see on the test for fevers, is what's it coming from.
I am done. That was everything from me now.